All right, I'm going to go ahead and jump in. My name is Alexis Whittam. I am the Director of Communications for the Colorado Coalition for the Homeless. Thank you so much for joining us for the CCH Education Series 2025. This is sort of our first session, sort of our second of this year. Last month we did our legislative preview, and so that's a little bit outside of what the Ed Series normally is, but it exists. And if you'd like to go back and check it out on YouTube, please do. It has a lot of great information about what's happening at the state level right now in terms of legislative matters. But today, what we're doing is our Homelessness 101. And we do this every year. And so if you've been here for a past one, welcome back. There's bits of new information. The reason we do it each and every year is because information changes. It changes in the way that CCH runs things day to day. It also changes in the statistics that we reference, and we always want to be as up to date as we can with data. So today is not a panel. Most of our education series are panels. Today is more of just presentations. So it's going to be me giving sort of a background of homelessness, and then two of my colleagues from the coalition, Sean Kiley and Brittany Melton Hill, will also present, and they work more directly with clients day to day, and so they have more details on sort of our day-to-day work at the coalition and how folks who may be on this session and want to learn more about our services can find out about how to access them. So what we cover is really, I mean, when we say 101, we mean 101. We do versions of this presentation for med students, for community groups, for high school students, even fifth graders. What we want is homelessness is a complex issue, and we want folks to understand. Really, if you came in and you knew nothing, you could get a pretty good understanding in this presentation, front to end. So we're going to talk about what is homelessness nationally, what is it like at the state and local level, what are the root causes of it, and we're even going to add a little bit of history this time. Then we talk about what we do with the coalition. The Colorado Coalition for the Homeless is just about to enter our 41st year. And so we've been doing this a long time, and we have a lot of institutional knowledge. And so we talk about our efforts. We work with many organizations and individuals in the community, but we talk about sort of our approach. And then Sean and Brittany are going to tell you about accessing CCH services. And finally, we've added some resources for community members because we do have folks who want to know, what can I do as an individual? So we have a little bit of information in here and some redirects to the website on that. All right. So little quick history of homelessness. We added this slide because, some of us, I was born in the 1980s. Many people who are older than me, who are older than many of us who are here, say there didn't used to be homelessness when I remember, right? They're talking about sort of post-war America. And the data kind of shows that, that essentially there have been periods of homelessness up and down, but that like post-war 20th century America really didn't have homelessness the way it is in our era, which would be sort of the mid 80s to now. So, in the 1850s, there began to be some homeless camps due to the rise of modern industrialism and the way that laborers would sort of move around to different work. Then, of course, the Great Depression in the 1930s, we saw, once again, it was more labor related. It was about migrant farm workers. It was about weather, leaving the Dust Bowl, and then, of course, like economics of the Great Depression. But from 1945, post World War II, through early 1980s, there was almost no homelessness. There were a lot of opportunities for people through the New Deal, which of course was FDR in the late 30s. And there were just wasn't the same amount. There were opportunities through the federal government that were allowing people. I apologize if anyone hears a dog barking. It might be cutting out in Zoom, or it might just be me hearing it. And then finally, in the 1980s, we see the Reagan quote unquote revolution, for those of us who remember it. And essentially, it was about deregulation, privatization, cutting taxes, shrinking the federal government, things that may sound familiar today, and what's happening at present, but really in many ways began with Reaganism in the 80s. And so at that point, we started to see a dramatic rise in the ranks of homelessness. return of encampments to the streets, and sort of in open spaces. And so in the mid 80s, Denver and 18 other cities received a grant from the Robert Wood Johnson Foundation for the creation of healthcare for the homeless programs. And that's how CCH actually started. We started as a healthcare organization. So just sort of a quick, hopefully, history to tell you a little bit of how we got where we are and sort of the modern era that we're in. And we'll touch on some of these points a bit later as well. So let's talk about what national homelessness looks like. There are, according to the official point in time count from the Federal Department of Housing and Urban Development, or HUD, there are about 771,000 people nationally experiencing homelessness as of 2024. By HUD definition, we're counting sheltered people and unsheltered. So sheltered people are staying in a shelter, unsheltered people are likely living on the streets, maybe in a tent, maybe not. A lot of people are not counted in the PIT count, and it is a very flawed system. One of the reasons it's flawed is it's voluntary. So the counting is done by volunteers, which means maybe if you're in a rural county, it's really hard to cover that amount of space and do the count. Other reasons it's not the best system is you don't count anyone who just on this one night that they decided to count each year isn't around. So somebody was in jail that night. Somebody was in the hospital that night. And these are people who would usually be counted experiencing homelessness. People who were in a motel that night. We know lots of people go in and out, and they're sort of in a motel one night and then maybe sheltered another time. Also, couch surfing, people doubled up, things like that. And doubled up in this context means maybe a house that's intended to hold 4 people is holding 8 people. Those are people who are doubled up, who our organization would consider to be experiencing homelessness, but the PIT count wouldn't. So in Colorado, that number is 18,715 as of 2024. But as I said, it's a flawed system and an undercount, and we would say it's an undercount at least 3 times under the actual number. Almost 4 if you look at that difference between the 18 and the 75. So the 75,000 here is people who've accessed homelessness services in Colorado in the most recent available year. They accessed HMIS. So basically anything that's a homelessness service provider, 75,000 people went and said, hey, I need help. I'm experiencing homelessness, or I'm eligible for homelessness services, right? There's a couple other counts as well that tell us that the numbers are fuzzy. If you look at students in the 2021 to 2022 school year, that's 18,000. That's just students in school under 18. And then if you look at individuals who are reporting to Medicaid that they don't have stable housing, it's 134,000. So while a lot of funding is based on the PIT count, the actual numbers of homelessness are much higher. But if we do just look at that PIT count, you're going to see a real recent increase. So, we would like 0 people to be experiencing homelessness. But you can see that from 2015 to 2021, it was around 10,000. It was pretty stagnant there. And then it's really grown the past few years. This is just in Colorado. So we're seeing that by 2024, that 18,000 number has hit. There's also types of people that differ over time. So you can really dig into the data over that time and see what changes there are. MDHI, the Metro Denver Homeless Initiative, does really great stats on this. And so they're looking at the 7-county Metro Denver area. For 2024, there were about 9,977 people in the PIT count in this 7-county area. 7-county area of Metro Denver is about half the state's population. It's a little more than half the state's people experiencing homelessness, primarily due to the fact that it's more expensive to live in most places in Metro Denver than most places throughout the state. Obviously, lots of exceptions to that if you're in Aspen or Vail, right? But some of the interesting changes that we found, or not changes, but interesting things for this year, 1 in 3 people are newly homeless. 1 in 3 are chronically, so that means someone who's been experiencing homelessness a longer time. And then within those demographics, 29% are unsheltered and 71% are sheltered. So we often get people who say, well, why are people unsheltered? Why would you choose to do that? Why wouldn't, why would you sleep outside in the weather that Colorado has in the dead of summer, the dead of winter? There's lots of rational reasons that our staff tell us that people choose to remain unsheltered that really makes sense if you think about it as a personal experience, right? Sometimes it's that they're overfilled. Sometimes it's that you're partnered with someone of the opposite gender and you would like to stay together. You're married. You want to go with your husband to shelter. There's men's and women's. You can't go together. You'd rather stay in a tent. You can't bring pets to shelter. Generally, you can't bring all your belongings. So maybe you've just been evicted. It's all of your photo albums, all of your furniture. You're really hoping you're going to get housing again soon. You don't want to give all that up to go to shelter, right? So that's some of the reasons. Another thing I'll mention just with some of the recent data is homelessness basically increased 10% this year, and there was a 12% rise in shelter usage. We also saw a big increase in the number of families. So from last year to this year, it went from 2,100 families to 3,100 families approximately. We also see discrepancies in racial demographics in homelessness. So at that bottom bar there, if you look at, or the bottom two bars, if you look at the general population and then the population of people experiencing homelessness, you're going to see a huge difference. While most people experiencing homelessness are white people, it is not proportionate to their percentage of the population. This is from Metro Denver Homeless Initiative. So this is specific to those 7 counties. So you'll see an underrepresentation in homelessness of white people, and you will see an overrepresentation in Black or African American folks, multiracial, American Indian or Alaska Native, and Native Hawaiian or Pacific Islander. This is due to discrimination that folks face, to historic barriers. This is not to imply that this would be any sort of choice differences or lifestyle choices. This is just people who experience more barriers in work, in housing, in life. We also see increased homelessness in other demographics. One is LGBTQ people, particularly trans people of color, particularly trans women of color. People with disabilities are also overrepresented. So, causes of homelessness. We like to talk about systems. And the reason we like to talk about systems is that the data tells us that systems are the reason for homelessness. We can focus on all these, but it's a long presentation anyway. And so, what I'm going to do is talk very quickly about the top 4 and then really dig into the 4 at the bottom because they have a lot of data that's really relevant. And if you look at the data, affordable housing really is the biggest reason. So generational poverty, this is one where, when I give this presentation to a group of maybe 8th graders, it's important to give examples of what this means outside of, a book, right? We talk about it in those contexts as, let's say your rent went up $200. Let's say that the timing belt broke on your car. Let's say that you got laid off from your job and you have another one lined up, but you have 2 weeks where you're not getting paid. Do you have someone who can loan you $500 or $1,000 and not miss it? Not be like, dude, I need my money back, right? Do you have someone who can help you out when times get rough? Because times get rough for all of us. If you have someone who can just hand you some money and not miss it, you're going to be able to avoid when the hard times come, right? Systemic and institutionalized racism, we still see today people discriminated against for housing, for all sorts of reasons related to race, related to disability, related to even veteran status. There are reasons why people are denied housing, and it can often be as simple as, oh, I liked the people who put in this application better than the people who put in this application, and that's how certain people get chosen. And so a lot of what we try to do in our advocacy work is work on ways to have fairness in the process of rental applications. And then, of course, purchasing of homes, the same thing happens, right? We know that Black homeowners have their homes appraised at lower values, often for the exact same house if the person who shows up is a Black or African American person. And we know that institutionalized racism had a real historic and sometimes present effect on access to housing and building the wealth that has been built post-World War II in housing. Public benefit barriers and restrictions. There's a lot of people who are eligible for benefits and don't get them. It's the applications are complicated. The applications are online, and some people don't have internet access. Circumstances change and you need to re-up your benefits. There's just a lot of challenges that come with actually getting your benefits that you are eligible for. And then also access to healthcare is one to just quickly touch on. We are a healthcare organization, and Sean will tell you more about what we do, but we certainly know that medical debt is a huge reason that people experience homelessness. Um, Having any sort of medical condition that keeps you from working causes people to fall into homelessness. There's a lot of intersectionality of once people are experiencing homelessness, they have worse health outcomes, which then catches on more. But today we're going to focus primarily on the four below. So we start first with wages. This is the hourly wage that a household must earn to afford a two-bedroom rental. And so the housing wage in Colorado is 37.47. You can see we're one of the darker blue states, and what that means is the darker blue states are more expensive to live in. So by this metric, we are the eighth least affordable state in the country. 10 or so years ago, I want to say we were the 16th. And so anybody who's lived here for the last 10 years has seen this happen and knows it's one of those things we kind of see and know, but are we actually seeing it in the data and thinking about its relationship to homelessness, right? So here in Colorado, minimum wage is 14.42, which is up from 7.78 a decade ago. That's great. That's way better than a lot of our surrounding states compared to, I'm sure many of us talk about when we used to make $6 an hour, right? But it doesn't buy housing because housing has gone up exponentially so much more than we've seen wages go up. So you need to make 37.47 to afford a two-bedroom apartment. If you work minimum wage, you'd have to work 104 hours a week to afford a two-bedroom. Now, whenever I give this presentation, people say, well, why do you need a two-bedroom? Can't people get a roommate? Can't people, get a one-bedroom? Well, first off, for a one bedroom, you'd still have to work 85 hours in order to afford it. And this is a modest one bedroom. But also everyone's different, right? You might need just an apartment for yourself. Someone else might have three children and need a, three-bedroom, four-bedroom apartment. And so two-bedroom is sort of an average. And this is from the National Low Income Housing Coalition and their out of reach report. Similarly, also from NLIHC, you see the affordable and available rental homes per 100 extremely low income renter households. So it's a bit of a mouthful. But if you look on the map, same states are darkly colored. And what that means is if you are a person who makes 30% of the area median income, so basically the average income for someone who lives there, can you find a place to live? Can you find a rental that you can afford and that is available to you? So here in Colorado, if you were at 100% of area median income, in Denver, that would be $73,000-ish for a single person and $104,000 if you're a family of four. So you're at 100% of the area median income. You make the average of a person in Denver. For every 100 of you looking, there's 100 affordable and available units. So it's a 1-to-1 ratio. As you go down to 80%, 80% AMI, someone who makes $55,000 a year as a single person or a family who makes 80,000. We think of these as a lot of our, a lot of voters, a lot of people who get a lot of attention that are, struggling, but not struggling as much as very poor individuals, right? And so if you're at 80% area median income, for every 100 of you looking, there's 89 units. So not perfect, but you can find something for the most part, right? But once we get to 50% and 30% AMI, it's very hard. And so if you're a single person in Denver, you're going to be making $22,000 a year to be at 30% AMI. If you're a four-person household, you'd be making $31,000 a year and be at 30% AMI. And so for those people, for every 100 of you looking, there's only 26 affordable and available units. And so the way we say this to our, fifth graders in the presentation is, before you take into account anything about this person, do they have a substance use disorder? Anything about their mental health, anything about their physical health, you're already playing a musical chairs where there's only 2 or 3 chairs for every 10 people looking. In terms of that housing affordability and what's changed recently and sort of the stats, this is just like a nice data slide for the people who love data. A couple of studies that we've looked at found that if there's $100 increase in rent, you see an increase in homelessness. So in one study, it was 9% increase in homelessness, and another was 15. Neither of these were in Colorado, but it does tell you that that's just a correlation. Rent goes up, homelessness goes up. Homelessness is about housing. That's what the data shows us. In Denver, home prices rose in the 10-year period between 2012 and 2022, 162%. So this means if you're a renter, rent's gone up. It also means if you wanted to buy and get out of the rental market, you probably couldn't afford to. And so a lot of people are still in rental units who would like to have bought and opened up those affordable and available units, right? Denver housing is 36% higher than the US average. There are 22,000 empty units in Denver Metro. I know I jump back and forth with Colorado, Denver, and national data, but it's supposed to just sort of give you the idea. But here in Denver, there's 22,000 or so empty units, but these are luxury units. So there is housing. But the housing that gets built is not the housing we need. And so nationally, most new construction is in the top third of rentals, not even for those 50%, 80% AMI, not even for the 100% AMI. It's for people who are very wealthy is what new construction builds because people are saying, hey, I can make more money per square foot the nicer I build. If I put more a fancy range, if I put really nice lighting fixtures. So we see that the top third of rentals, that's most of what's being made, and less than 7% is for the lowest third of rentals, but those are the majority of people who need housing. There's a great study by a guy named Greg Colburn, who's a professor at the University of Washington's College of Built Environments. And he did a study with data journalist Clayton Aldern that measured the correlations between homelessness and other factors. And so all those factors on the right, mental illness, generosity of public assistance, drug use, poverty, more desirable climates, those are things they heard were the reason that people experience homelessness. So they said, let's look at it. Let's do the data. And what it turned out when they dug into the data was that the strong correlation with homelessness was housing market conditions, including median rent, rental vacancy rate, high population growth versus low supply elasticity. And so that's what we see is that even though people want it to be about these other things, maybe not want it, but believe homelessness to be about these other factors, it's actually from a data perspective not the most relevant. A little bit more back to our sort of history slide is this 1980, early 80s period. That's when essentially we stopped making affordable housing. And so once again, if the government isn't encouraging people to make affordable housing by subsidizing it, people who are builders work within a capitalist system and they make the housing that makes them the most money. And so they make the high-end housing. And so since 1980, almost all affordable housing is down. It's less than 7%. And we also see that the housing choice voucher program just isn't utilized enough for the people who need it. So many people, once again, are eligible and they simply don't receive the vouchers or assistance. Only 1 in 4 who's eligible does receive it. Criminalization is another thing that we hear about regarding homelessness, that's going to be a solution, right? So now someone has lost their home, they are experiencing homelessness. The way to solve it is to criminalize it. So across Colorado, there's over 350 anti-homelessness ordinances. Some of these are in small towns, some of them are in big cities, and it really varies quite greatly. So some of them are the types of activities that would be legal if you were housed, right? Camping, sleeping, sitting, lying down, loitering, storing property, sharing food, solicitation of money. So we will have a lot of clients who have who have criminal records. A lot of it is for things that are simply just living as a person experiencing homelessness. Someone experiencing homelessness is 11 times more likely to be arrested than someone with housing, often once again for these, crimes that are simply crimes of poverty. And camping bans have not been shown to resolve homelessness. When there's a sweep, it results in confiscated or lost property, sleep deprivation, injury from exposure. People often lose their vital documents in a sweep. They lose the possessions they do have. And so criminalization just simply isn't effective from a data perspective. It's also inhumane. Personal barriers. So we do mention personal barriers. There are some that are really noteworthy. We're going to talk a couple on the next slide. For instance, on this slide, domestic violence is one. That is the number one reason that women experience homelessness. But if you think about these in and of themselves, how many people do we know? Most of the people, many of the people on this call are housed, right? That have experienced one, two, five of these, right? Mental illness, job loss, eviction, physical disability, family breakup, domestic violence, substance use disorder. That's not leading to homelessness in a bunch of people that we know, right? What is when it's in certain market conditions that these things are happening, and when people's income is low. And so that's just the thing that we like to mention in terms of personal barriers. It's not to say that it doesn't have any effect. It's just that this incident, without the other factors, isn't causing homelessness. One of the things that I would say is not necessarily a personal factor, but it is an individual, it has an individual impact, is adverse childhood experiences. This is one that data tells us is relevant. A person's experience is relevant to their likelihood of homelessness. And those are adverse childhood experiences. This was a study that happened somewhat accidentally through Kaiser in the 90s, where essentially they looked at people who had traumatic events through the ages of 0 to 17 and what the impact is on it. And so you can take like a very simple 10-question test and figure out your ACE score. And the higher your score is, the more likely essentially you are to experience homelessness in adulthood, the more traumatic things you experienced as a child. And that's because these experiences cause toxic stress in an individual. It can negatively affect a child's brain development, immune system, and stress response systems. And therefore, in adulthood, it's linked to chronic health problems, mental illness, substance use problems, and can negatively impact education and job opportunities. And here on the left, you'll see that chart. So essentially, at four ACEs, your likelihood of experiencing homelessness goes significantly up. But when our clinicians talk to us, what they tell us is that, they're not giving the ACE test to most of our clients. They're assuming that everyone who walks in the door is traumatized and needs trauma-informed care. And the reason is that whether or not you experienced trauma as a child, you're experiencing it as a person who is unhoused. It is very traumatic to live unhoused in our community and to be having to worry about, your basic needs day in and day out. And so that's why we have a trauma-informed care approach. So, okay, that's a lot of heavy information on where we are in homelessness, and now we talk about how to combat it. So, there's a couple, I'd say, I don't know that these are the only two approaches, but they're two of the big ones is sort of emergency responses and then long-term stability. So, emergency responses are like, what do you need today? You got to eat, you got to have a roof over your head, maybe a hotel voucher for the night. It's cold, we're going to open up a place for warmth. And then there's long-term stability, and these are the things that can help people longer term to find stability when they have been unhoused or are currently unhoused. And some of these will continue, like long-term stability will continue often, even when you're housed, you'll continue to have some supports. So here at the Coalition, we do four things generally. We do housing, healthcare, supportive services, and advocacy. So we'll start with housing. We have 23 properties. Our properties have a combination of permanent supportive housing, affordable housing units, where people essentially pay 30% of their income and they can use a voucher. And then transitional housing, where someone has an opportunity in between. They're waiting for something to open up that's more permanent. So on any given night, we serve over 4,400 people with housing. About half of those are in our 23 properties, and half of those receive vouchers from one of our other programs that helps people. And this is sort of all within a housing system that's happening more generally. But just sort of, as an organization, we prioritize these four things. But I would say housing and healthcare are sort of the meat and potatoes of what we do. So permanent supportive housing is the one that we talk the most about because it is a model that's just proven to work. I do say this a lot. We try to have a database presentation. We're happy to send resources to folks who want to see it. And what we call this is sort of housing first, but not housing only. Housing with supportive services is how we think of it. So the idea is some people want treatment first. They think in order to get housing, you should get treated for a substance use disorder, or employment first. In order to get housing, you need a job. And what we believe is in order to get housing, you should get housing, and then everything else can come together after that. And the reason is that that is data proven to work. It's also very logical, like how, first of all, 40 to 50% of people who experience homelessness work in the calendar year of their homelessness. So people are working and they're working hard and they're experiencing homelessness because of that wage disparities we saw in the blue map. And so that's, it doesn't solve everything to have a job. It also doesn't solve everything to not have a substance use disorder. The solution to homelessness is housing. So, in our permanent supportive housing that we have at CCH, residents at our facilities, they're offered wraparound services. So, what you get is on-site case management. Usually, that's a case manager who's at your building certain hours. So, it's not all of our properties. We're moving things around. We have a lot going on, and we have properties dating back to 1996. But usually, you can talk to your case manager right on site where you are. But either way, you have someone who's the person you talk to who you can build a relationship with and trust to help you while you figure all these things out. That person can then get you hooked up with counseling, substance use treatment, psychiatric care, medical care. And those things are all, sort of at will. But our studies show is that when people are housed, they start to say yes to those opportunities once they're not worried about where they're sleeping at night, where they're getting their food, right? There's also proven outcomes for this. So our social impact bond program gave us those results that you see under this picture of David in on the slide. David is at one of our properties and he got housed through our SIPR program, which is quite similar to SIB. But essentially, when you give someone housing, what they're going to find, you're going to have 80% retention in that housing after 3 years. You're going to have a reduction in arrests and you're going to have fewer ER visits for those people. You're also going to have more primary care visits. And so what ends up happening is that person is not only like being served in a humane way and able to like choose their path and lead from what they want, but it's also cost effective because what we're doing is that person is no longer going to detox often. They're not going to the ER every night. They're not going to jail for crimes of homelessness, right? And so it's sort of an approach that's both humane and also logical from a tax pointer point of view. Um, and another example of that, or just, sorry, to expand on that a little bit more, this is a little bit more about permanent supportive housing. So this is another client of ours, Wendell, and the coalition essentially can provide supportive housing and services for less than the cost of medical care, incarceration, detox treatment, and shelter services. So this is why this is what we believe. Now, that being said, it's a tough model because you have to build housing and housing is expensive and it takes a long time, right? And that's why, if you follow us, you'll see that sometimes we build a new building like the Renaissance Legacy Lofts. Sometimes we try to convert a hotel because it's very hard to have enough housing to happen fast enough to keep up with the number of new people falling into homelessness and just the number of people experiencing homelessness. And it's such an expensive state. The second thing we do is healthcare. Normally in our one-on-one presentation, I would have a few slides on this, but I'm just going to give you a little bit because Sean's going to tell you more later. But what we do in our healthcare, which was indeed how we started as an organization, is we serve about 15,000 people a year. It moves a little bit up and down. This is medical visits. This is mental health visits. It's all kinds of visits. We have dental, lots of programs. We even have optometry, pharmacy. Our pharmacy is about twice as busy as your average Walgreens because so many of our folks need a large number of medications. That's because homelessness is really hard on your health. Homelessness is associated with a 15 to 30 year reduced life expectancy. When I do these presentations with our doctors and nurses, what they say is that, when I'm looking at a 50-year-old client who's been experiencing chronic homelessness, I will look for conditions more like that of a 70-year-old housed person because of the toll that it takes on your body to experience homelessness. So homelessness and health are incredibly intertwined. People experiencing homelessness have an increased likelihood of experiencing violence, a higher risk of traumatic injuries and assaults, right? Whether that's in community, sometimes people who are outside of their community injuring them, pedestrian fatalities from cars, all sorts of exposures that just as a housed person, you just don't experience in the same way. And then, of course, exposure to extreme heat and cold. We know that the climate here is not conducive to being outside much of the time. There's a lot of conversations about, one day climate change is going to make it unlivable. Well, if you're unhoused, it's unlivable right now on many days of the year, right? And in some places, like in Denver, we're opening up warming and cooling shelters, but we're not doing that everywhere, right? So we see people every year at our vigil for people experiencing homelessness who died in the previous calendar year. We see people who died from heat and cold exposure. And so our doctors often say if I could prescribe housing the way I do medication, I would. Supportive services is everything else. So, as a 40-year-old organization, we're a little bit overgrown with like programs that you're just like, I don't know how we started that once upon a time, but we have a lot of different programs that support people sort of once they're in our network, they're in our housing or they're in our healthcare community, they have access to other things. So maybe that's specific veteran services. Maybe it's employment programs. So we do have employment opportunities here. It's just not the first thing we offer to people, right? Um, we have some rural support, and we have many others that are listed here that you can learn more about on our website. I want to make sure we have time for my colleagues to speak. And so I'll just touch on one that I like to speak on, the Fort Lyon Residential Community. This is located in Southeast Colorado in Los Animas, near Los Animas. And what it is a place that people can stay for 3 months to 2 years to work on their substance use disorder, whether that's drugs or alcohol. And most programs just don't offer that. I mean, even paid programs for people who are housed, it's very hard to find something more than 30, 60, 90 days. And so when you're at Fort Lyon, you can really settle in, take the time to work on, the reasons that are intertwined with substance use disorders. And so this is Randy. Randy is our community reintegration specialist. And this is his quote about Fort Lyon. I'm very blessed to be able to work at Fort Lyon. Being a previous resident, I can come back and work with residents who have the same issues I had and be able to let them know what they can do to move forward. It's possible for anyone if a man like me can do it. And if you want to learn more about Fort Lyon, I will ask maybe Gabriella to put in the chat our Fort Lyon page, and it has a link to a video from our 10-year anniversary last year that can tell you more. Finally, the fourth thing we do is advocacy. So we're in the middle of 2025 right now. Legislative session will happen till early May. But last year, we had our wonderful advocacy network send messages to legislators for Colorado bills. And 51 of the 58 bills we engage with had the desired outcome. So we try very hard. We have a dedicated advocacy team. They are currently right now in DC at the National Low Income Housing Coalition Conference, working, talking to our federal leaders. You might see it on our social media in the next day or two. And so we work at the federal level, we work at the state level, we work at the local level. We generally work in these four priorities: affordable housing, homelessness, health, and economic justice. So those are kind of our, like what we always do. Every year we announce our four concentrated areas, and they're kind of always the same, but you never know. It could change one year. Some examples of that in housing, we talk about affordable housing, we talk about land use, anti-displacement, accessibility. Renters protections are huge. One from last year was a bill that just made it so that if someone was in eviction court, they didn't have to pay the $84 to defend themselves from eviction. $84 is a huge amount of money if you're behind on rent. And so by waiving that fee and having an opportunity to waive that fee, that gives people a fighting chance, right? Also, rent multiplier is a big one. I know people who've moved here from other places and say, oh, like, when I was living in Illinois, they asked me to have 8 times the rental income in order to apply, and here it only had to be 2 or 3. That's because of these types of bills that have renters protections. And then healthcare. We're a healthcare organization, and so we work on healthcare, we work on substance use disorders. You can sign up on our website and get sort of our weekly updates or monthly updates on what we're doing for advocacy. Some of our bills this year, I will not do these justice. If you want to learn more, last month's session is great, and you can find it on our YouTube page or on our website, on our video page. But this year we have a couple things we're prioritizing that we're sort of taking the lead on. The first is an infrastructure bill. So It's basically to reestablish an interagency council on homelessness and allow there to be more of like a statewide understanding rather than so different in different jurisdictions. This is really important, especially as we see federal changes, to have more of this sort of um, all together and with a logical approach that is a singular approach from a statewide level. Secondly, you'll see the Adjust Necessary Document program. This is just a way to help people get documents like IDs, driver's license, birth certificates, all these things that you need to access housing, housing, healthcare, employment, bank accounts, all that. There's like a really cumbersome system right now with like physical forms, and we're trying to just take away some of the red tape. And then finally, 1168, HB 25 1168 strengthens protections to improve housing security and expands access to courts, and upholds due process protecting the safety and privacy of victim survivors. So that's it for sort of the big homelessness 101 that we generally have. And so what I'm going to do now is pass it over to Sean to tell us about accessing services, healthcare services at CCH. And I'll keep driving, Sean. So just let me know when you want me to go to the next slide, please.
Sounds good. Thanks so much, Alexis. And you do an impressive job of covering a lot of ground in those slides. So like Alexis talked about, healthcare is one of the main pillars of services that we do at CCH. We see a lot of patients every year for a variety of services. So I'm just here to tell you a little bit more about our healthcare services and specifically accessing our healthcare services. You can go to the next slide, please. So you can see our various services that we do in healthcare that are listed out there. You can see that there's quite a few. I'll tell you a bit about our model of care at CCH. We are a accredited patient-centered medical home, which means that we're providing a diverse set of integrated services, and they're centered around both the physical and mental health care needs of patients. Our goal really is to be a one-stop shop where we can make the transitions between types of services as seamless as possible. Um, think about it, if you were going to one organization for your primary care medical per se, and then you disclose that you needed maybe some therapy or psychiatry outside of the scope of what they do. You have to get a referral, and then you have to follow up on the referral. Here we try and make that transition as seamless as possible. Even whenever possible, doing warm handoff. So if somebody says in a primary care visit, let's say that they have housing instability and are interested in meeting with a case manager, the primary care provider will call somebody right then and there and do a warm introduction handoff and get that person connected with that other service line. So of the services that you see here, there are a couple that I do want to highlight. One being our medication assisted treatment program, which is MAT for short. If you're not familiar with it, medication assisted treatment is the use of medications like buprenorphine, commonly known as Suboxone. There's also injectable versions called Sublocade and Brixadi. And these are methods that keep people off of opiates. They're opiate antagonists that prevent basically cravings for opiate use. We really strive to be an extremely low barrier MAT program. It is a walk-in based program. Someone does not have to be referred to our MAT program in order to engage in our services. They can walk in our door for the first time, having never been here before, and get seen for MAT services same day. And then when they are due for their prescription, they just come in again. We run it every afternoon that we're open at the Stout Street Health Center. Another program that I wanted to highlight is our eye clinic. Generally, we really take a no wrong door approach where somebody can come in for any of these services and then we'll connect them to the other services that they might need. One of the few programs that you do need a referral from primary care for is the eye clinic. And the reason for that being that our eye clinic is entirely volunteer run as far as the providers. The staff who work the clinic are CCH employees, but all of the optometrists and ophthalmologists that see patients are volunteers, which we're so lucky to have that as a resource. It's really not a common thing for a community health center like us to have an eye clinic, and honestly, we wouldn't be able to afford to do so if it weren't for those volunteers. So I just like to shout out that program because I think it's so unique, and I'm thankful to our volunteers who make it possible. And another thing I wanted to highlight is that we also do a great deal to assist our clients in navigating any services that they might need outside of CCH. We are an outpatient primary care clinic in that we are not able to provide every service that our patients may need. And, they may need a specialty referral or a surgical procedure. That's something that is just not within our scope. But we have a team of patient navigators who work with our clients. So if there's anything that they need outside of here, we make sure to do everything that we can to get that referral to completion so that they get that needed service. Next slide, please. And you can see a little bit here about a few of our locations. If you want more information about the addresses or hours of operation, you can look at our website. And each of these sites is a little bit different. Stout Street Health Center we refer to as kind of the mothership. So all of the services that you saw on that previous page are available at the Stout Street Health Center. Some of these are smaller satellite sites where they may have a few of those specialties, but not all of them. So for example, our eye clinic is exclusively at the South Street Health Center. Um, our dental clinic is at the South Street Health Center as well, but we do outreach to some of these locations. So for example, our 48th Avenue Health Center is actually based within one of the largest shelters in Denver that opened up about 3 years ago. At this point, there's both a men's and women's shelter over off of Colorado and 48th, about 750 people there on any given night. And our shelter-based health center, we do primary care, behavioral health, and we also do dental outreach and evaluation. Since we don't have all the specialized equipment that we have at our main health center, anything that's more complex than what we can handle at that satellite site will refer back to the South Street Health Center for additional care. And we also have our Fort Lyon Health Center. Alexis just referenced our Fort Lyon treatment community. We also have a health center that we operate down there where people can get their primary care and psychiatric needs taken care of. And then there is also our Stout Street Recuperative Care Center, which is a really amazing program. It is for people who are post-hospital discharge, who are well enough to leave the hospital, but are not well enough to return to the streets, and they get post-acute hospitalization care in a 24/7 facility. They get supplied 3 meals a day, and our staff take really great care of them over there. So that's an excellent program and a very needed program in our community for sure. I also want to talk a bit about our health outreach program. That is our RV style medical program. You can see a picture of the RV right there. You might see us driving around the Denver metro area. We go out and provide services 4 days a week, and generally we have some regular sites in our rotation with homeless service providers in the Denver metro area. There's 6 regular sites that we go to that have pretty regular need for our services, and then there's a few other that we rotate in periodically that maybe have less frequent need. We go there once a month, once a quarter, things like that. But of our 6 regular sites, 3 of them are day shelters. We go to a 24-hour shelter, and we are also the contracted service provider for the mayor's All in Mile High program. The hotels that were converted into transitional housing. Some of them have spaces where we could operate indoors, but for the ones that we are not able to operate indoors, our mobile medical vehicle provides services to them. It's primarily primary care medical focused, but we do occasional behavioral health and dental outreach services. The vehicle's not really set up for specialized dental services, so similar to our satellite sites, we'll do evaluations and refer back to our primary sites for that. Next slide, please. How to schedule with us. So we have some nuances to this that I'll try and make clear for this. And one of those nuances is the definition of established patient versus new patient. So uh, we get a lot of questions on this on like what is an established patient? Who do you consider to be an established patient? And we consider somebody established to be anyone who has seen CCH for any services at all, ever. So if we have a chart for you in our record, whether that be housing or healthcare services, you're considered to be established with us. You would be considered a new patient if we do not have a chart for you. You have never accessed our services in the past. So our satellite sites are accepting new patients. South Street Health Center, which is our main site that I've discussed, we are accepting new patients on a small scale, particularly our medical and dental services. We're really at our capacity to take new patients. So over the past year or so, we've really had to scale back the number of new patients that we can take into those services. There is an integrated intake process that we do once per week to intake new patients. I put a link to our website where you can get more information about that. And basically what it is a comprehensive intake. You meet with a case manager who assesses you for any housing needs that you might have. And then they're also evaluating any of our healthcare type services that you might need. So that's the process to get established at South Street Health Center, but our satellite sites are accepting new patients. So I just want to make that part clear. Next slide, please. So a couple frequently asked questions that we get. What do you need to access services? There's nothing that you need to bring with you, just bring yourself. However, there are some things that are always helpful to us if you do bring them. If you have a photo ID or some form of identification, always helpful to bring that. Insurance card if you have one. And for anything that you're seeking related to your health, as far as any appointments that you have, and any recent hospitalization, discharge paperwork, or a list of current medications, or even just the bottles, if that's all you have, is always helpful and lets our doctors really focus in on what they can do to help you. If you're bringing a child in for an appointment, any vaccination or immunization records are always helpful. That kind of leads into our second question that we get a lot of: are services available to children and teens? Yes, they are. We do see people under 18 years of age. Just a note on that, like many things, people who are under 18 do not have legal standing as far as being able to consent for things when this includes healthcare. So if somebody under 18 wants to receive services for us, they have to have parental consent to do so. So a parent has to accompany them. There are certain legal exceptions to this where somebody can seek treatment without parental consent. Either that minor is legally emancipated, or there are certain service types that you can seek under 18 without parental permission. Substance use treatment is one, prenatal care would be another one as an example, but there are a few other exceptions as well. And then third question we get a lot is, how can I reach my doctor between visits or request a new appointment? CCH does have a patient portal which clients can use to message their care team. A nurse will respond to that message within 72 hours and touch base with the person's primary care doctor if needed. You can also request appointments through the patient portal. You can also call us to request appointments, but I always advocate that people use the patient portal. It's a pretty efficient way to do it. And you can also request medication refills through the patient portal as well. And if the patient portal is something you're interested in, you're currently a client of ours and you are not enrolled yet, next time you come in, just talk to somebody at the front desk. We can send you an invite to get enrolled. It's really easy to get set up. All right, I am going to hand it over to Brittany Melton Hill, who is an outreach program manager, who's going to talk a bit about our community outreach and engagement services.
Thanks so much, Sean, and to Alexis for starting us off today. Like Sean said, I'm the outreach program manager, which is our outreach team is a part of our outreach and engagement services department, which we'll talk a little bit about. I'm glad to follow Sean because a lot of our services, both through the clinic and at DOES, are the front-facing services that you think of a lot of the times when you think of accessing services through the Coalition for the Homeless. We're often the first face that clients see when they're trying to get connected to those services. So yeah. So what are we talking about when we're talking about housing? There's lots of different types of housing that people can access. When they say that they want help applying for housing, there's all these different types of options that we can pursue with them. These are all options that are for folks who can't afford like the normal fair market rate pricing. And they're all subsidized by the federal government. So Section 8 is what most people think of when they're asking for support. Section 8 is done through housing authorities the majority of the time. And that happens for Denver 2 days in September. And so there's a huge misconception about Section 8 as well, that if you sign up for that lottery, that you're good for years and years and years, and that your name will eventually get pulled. And that's just not the case. You have to re-sign up every single year. So we do a lot of supporting people sign up for those options. That Section 8, it's just a voucher. You can take it wherever. And then our advocacy team has done a lot of work to help make sure that landlords know that they have to take vouchers. You legally cannot discriminate against folks who have vouchers. So that apartment could be anywhere in the city. Sometimes that comes with utility support. Sometimes it doesn't. It just kind of depends on what Section 8 you're going through. And then we have low income tax credit housing. This is a more affordable housing option than fair market rent, but a lot of our clients might not qualify for this type of housing because the amount of rent that you pay doesn't depend on your income. So like Alexis said earlier, AMI, the average median income, that amount that you get each year is how people figure out what your rental costs are for all the other types of housing listed on here, except for low income housing tax credit places. So that would be, might be like $800, $900 a month, but still is a little bit more affordable than your regular, like normal fair market housing price. And then HUD 202s and 811s. If you hear people talk about subsidized housing, that's usually what they're talking about, even though all of these places have housing subsidies. These are, there's all sorts of different apartments across the city, across the state, the nation that are these type of housings to apply. You have to fill out a paper application, mail it in, and the wait lists are very, very long. They can range from 3 months all the way to 5 years, 6 years, 7 years. So it's really, it's not advised to just apply for one place. You're really applying for as many places as possible if you're signing up and applying for HUD 202s and 811s. For this and for Section 8, and the next type of housing, permanent supportive housing that I'm going to talk about, people pay 30% of their income for rent. Which is really helpful. When we do our case management in our department here, and with the integrative case management that Sean talked about earlier, filling out these HUD 202 and 811 housing applications is like the meat and potatoes of what we do. Where those are flying off of our mailboxes to get into the community, so that we can make sure people have an option to pursue. Most of these options are going to be, you're going to qualify if you have a disability. So that could be a mental health issue or a physical health issue, or you're a senior. In some cases, this means 55 plus, but a majority of the time, the apartment places are wanting seniors to be 62 plus. So it just kind of depends on the property. Each property is different. And then the permanent supportive housing and coordinated entry we'll also get into a little bit in a second, but this is the only type of housing listed on here that comes with case management and that lifetime supportive services. I think at the coalition, we know and we fully believe that just because someone gets housed, it doesn't mean all their problems go away. Alexis mentioned earlier, like we are housing first, but then there's like the next step to that housing process, and that's housing stabilization and helping people find those supports around. You know, a lot of people move into housing and find that you know, they're not having to survive anymore. So a lot of their problems or trauma might come out in a way and affect their mental health or substance use in ways that they didn't when they were living outside still. So there's many ways that people can get connected to housing, lots of different options. But the main point is there is not nearly enough housing for people who need it. There's not enough affordable housing. There's not enough subsidized housing. We're woefully undersupplied in that area. And so that's why it often takes so long for people to get connected to the resources that they need. You know, so many more people are qualified and eligible for this housing than we have the actual like property capacity for. Can you go to the next slide, please? So this is kind of a fun picture to show why coordinated entry is so important. So the Metro Denver Housing Initiative, Homeless Initiative, MDHI that Alexis talked about earlier, they help the city, the Metro Denver area, kind of coordinate and match our permanent supportive housing options to hopefully like the most vulnerable folks, the folks who need it the most. And so having that one coordinated entry means that you don't have to know the right person or be connected to the right person to get connected to housing. You can have many front door entrances to get connected to that option. Otherwise, like I said, you might have to go to the right place, be at the right place at the right time. And then that just isn't a fair and equitable way to match these like very valuable resources to people. There are cons to coordinated entry. You know, some people might get passed over who should get permanent supportive housing, but get skipped over because of whatever priority system they're using at the time. But for the most part, I would say that there's a lot of pros to this system, and it does a good job of matching people to the services that they need. Next slide, please. So this is the new way to sign up for our case management to work on housing and other services I'll talk about on the next slide. This is the way that you would get connected to that integrated case management that Sean talked about. We used to have people sign up or come to our building. And the first 10 people who showed up would get case management that day. And we had people showing up at like 2 a.m. the morning before, and that's just not safe. It's not fair for us to ask. So instead, we're having people sign up online. And then on Monday, we start making calls to tell people that they'll have appointments on that upcoming Wednesday. And the idea is they come in for case management. We can immediately get them connected to behavioral health care, and then also the other medical care options that we have over at the clinic that Sean mentioned. Next slide, please. And we have this for individuals and we have it for families. For individuals, we take 20 new individuals each week. That happens on Wednesdays. If people don't have phones, they can just come into the building on Tuesdays to check if they got that appointment. It's really important to know that, like I said, waiting lists are really long. We don't have any immediate housing options or sheltering options that we're able to give people when they show up for those appointments. Next slide, too. And then we also do the same thing for families, but we see 6 new families each week. The family housing system is a little bit different. So we have people specially able to help with those housing systems. We don't have any priority access to family shelters either, but families in need of shelter should call the Connection Center phone number listed on this slide. Next slide, please. So yeah, we already talked about this. You can go to the next slide. With our case management team, we aren't just doing housing. We're also helping people connect to all sorts of different services. Can you go to the next slide, Alexis? And those are all listed here. You know, there's lots of things that people need to be able to be housing ready. So a lot of that is helping people get their vital documents. That could be replacing permanent resident cards. We're trying to refer people to shelters or alternative to shelters like the All in Mile High sites when we can, referrals to other agencies, to the clinic, helping people with benefits, just kind of working wherever people are and what they need assistance with. And then if it's not something that we can do at CCH, making sure that we refer them to the appropriate resource. So I don't want to take up too much more time because I know we want to save time for Q&A. So I'm going to hand it back over to Alexis.
Thank you, Brittany. Yeah, so just a couple more slides. At this point, what we've covered is sort of, excuse me, the 101 for everyone. We've covered information for people who are looking for services, or if you have clients who are looking for services. And so we just wanted to add a little something on the end this year about resources for community members. We're hoping to have a session later in the year, sort of a how to be a good neighbor type session, because we get so many people asking what they can do. And so that answer is different for everyone, depending on your resource, depending on what you personally have to offer, want to offer, right? To help neighbors. So this section is more for our housed folks or unhoused folks with time. What can we do to help others? And so we're going to go through quickly and then be sure to have a little bit of time for questions. So first, community education. That's you right now. Learning is great. This will be up on YouTube soon. Be sure to share it out with people. We'll have additional education series this year. We do take into account what people write back to us. Take the survey. Tell us what you think of this one. Tell us what you think of other ones. We use that to inform our choices for this year and next year. We're pretty well scheduled for this year, but things can always change. But we do want to announce what we have coming up immediately. We actually have an in-person film screening in April. A partner organization is made the film Beyond the Bridge, and so there will be a slide for that at the end. You can go to our website, coloradocoalition.org/education series, and you'll see a link to sign up. So it is a free in-person screening in Denver on April 22nd. Then we'll have a veterans and homelessness session in May that'll be virtual like this one, and another one in June called on extended health services. So we're going to dig more into what Sean was talking about, some of our lesser known health programs and their impact. So optometry, dental, things like that. We will probably be trying a different time in the summer, see if some sort of lunchtime options work well for people as an option. We're always trying to figure out what's the best way to get folks here and involved and what works for you. You can catch up on past sessions at youtube.com/@coalition. You can also read our reports and issue briefs if you want to dig more into something. Earlier when Brittany was talking about older adults and homelessness and different opportunities, special populations have special needs, so we try to write reports every few years on different topics. This year we just released one on older adults and homelessness. We've done them in the past on LGBTQ folks, different folks in homelessness, or different topics like climate change and homelessness. We do this presentation for community groups, schools. You can find a link to how to apply for that on our website. And then you can always join our email list and follow us on social media just to stay up to date. You know, sharing out this information can really help in convincing friends, family, people you know about homelessness and this information that hopefully helps people to see that it's a systemic issue and not a personal issue. Next, community action. We have a community action page. It's coloradocoalition.org/community action. And basically it mostly is going to just redirect you to other pages that we already have about how to volunteer, how to donate, how to join our advocacy committee and go to lobby day like these folks did in the photo here. We have already had our lobby day this year, I'm sorry to say, but there's still a lot to do online and a lot of ways to follow along and be involved. So if you go to the community action page, you'll find links to all that. You also on the community action page will find our sort of what can I do document. It has sort of tips and tricks for people. We get asked the same questions a lot. You know, what do I do as a person in my community? One thing we like to tell folks is that if someone is living near your house in your community, they're probably from your community. There's a lot of misconceptions that people move. These aren't our people here. We don't have problems with homelessness. People are moving from another city. People are moving from another part of my city. Typically, a neighbor who's a neighbor in your community is a neighbor in your community. They likely lived there housed before, right? So people ask, what What should I do? So, we give tips. Everyone should make their own decisions. There's more resources on the page. There's lots of other organizations that will have other ways to give. You can do mutual aid. You can make a meal for Urban Peak for the youth. But we try to give some tips here. We hear a lot from clients that it helps to just acknowledge people. They ask you for money, just say, hey, how's it going? You having a nice day? Anything that humanizes someone and makes them feel seen and respected in community can be helpful. It doesn't cost you anything, right? Making eye contact, saying hello. Giving food or money is something that if you can, you do. I have a colleague who talked about keeping single dollars in her car, keeping like fruit roll-ups to be able to hand to people something that's easy. Other people say, I always ask what someone wants. If I'm going into the 7-Eleven and I don't have any cash and they say they're hungry, well, what do you like, right? Not just assuming. Another tip is about criminalization. A lot of people say I want to call the police, and we just always like to say stop and think. Would you call the police if what the person was doing, if the person to you was perceived as housed? Now, not all people experiencing homelessness, you're not going to know. You're probably encountering lots of people experiencing homelessness who you don't know are. But I can drink a beer out in public when I'm going to the Rockies opening day next week. And I'm probably not going to have anybody call the police for my open container, right? And so, why are you considering calling the police? For what reason? Is there a danger, right? A danger to someone or to others. So, if you're in Denver, you can always use STAR. I just save it in my cell phone. If someone is having a mental health incident, they might be a danger to themselves and others. Let's try to get them a mental health responder rather than a police responder. We know that police responders often aren't effective at getting resources to people that they need, and it can lead to criminalization or worse, which is going to impact that person's ability to maybe get to their job the next day or have their visit with their kid the next day if they're locked up that night, right? Not to mention fines. And then we did make a what can I do document on the community action page, so check that out. And feel free to give us feedback where, it's always a work in progress. What we think are the questions people want answered change, and so let us know. So we are running to the end of time. We try really hard to respect the end of time, but I am gonna look at our Q&A and see if there's anything we should jump into. Okay, did I stop sharing? I stopped sharing, right? Okay, so I'm going to answer this one from Roger, or I'm going to ask it, and maybe Sean can help me out in this one particularly. It says, you have an impressive list of resources you provide. Do you have challenges finding qualified staff to provide these services? If so, what areas have particular needs, and what is being done to meet those needs? So thank you, Roger. And Sean, I think medical is where we have one of our biggest needs, so I'll start with you.
Yeah, and I'm sure Brittany has some thoughts as well, but we're almost always hiring. We I feel like we only scratch the surface of like all the different services that we do at CCH and all the different programs that we run. I would say case management is an area that we're always hiring in. Medical assistants in particular are in super high demand, and there's a lot of competition for medical assistants across all the various places that employ medical assistants. So those are the two that jump top of mind as far as positions that we're almost always hiring for, and we're always recruiting as well as far as the question of what are we doing to do that. We do a lot of, not as in depth, but a lot of what we just did right now, a lot of education out in the community. We'll go and actually present to medical assistant institutes, places where people are being trained for these professions to really introduce them to our services, get them familiar with us. We definitely have people come in and shadow us and learn about us. We take residents when it comes to our medical providers. We have a program where we bring in residents to get familiar with working with the homeless population. So we're always looking for ways to show people what we do, because we're super proud of the work that we do, and it's so essential, and we love the work that we do. So we're always trying to bring people into that and show what it would be like to work here.
I don't have anything to add from what Sean said. He hit it on the head. So
Okay. Yeah, we have another question. And it is, sorry, I minimized my screen foolishly. No, I can't find it. Okay. In listing conditions that are not correlated to homelessness, you did not mention addiction. Is substance abuse a reason people are homeless? So, it's certainly not zero. There are some cases where someone's substance use led to homelessness in the same way that substance use can lead to job loss, family breakups, things like that. There was a recent study, and I was trying to find it in my email and I couldn't fast enough, but about a study in California where they find a lot of drug use increase once someone's experiencing homelessness. So not to say that people weren't using substances prior to it, but either starting to or increasing the level due to the trauma of homelessness. One of the things that I hear from a physician of ours who I do these presentations with for med students is that a lot of women he meets who are addicted to methamphetamines mention that they started using it to stay awake at night because they were worried about sexual assault. And so they started using it for a very specific reason related to being unhoused, and now they're addicted because that's what it is with methamphetamines. And so, it's not a 0% correlation, but I do think that the data shows that it is more pronounced as increased once someone is experiencing homelessness, just like a lot of negative outcomes increase. So I'm going to go ahead and end it there. We usually go till 6:15, so we've pressed just a little bit. And I apologize, I'm getting my slides ready. Really a sausage is made moment here. Usually, my lovely colleague Gabriella shares slides, and so I'm sharing today, so you all get to experience that. But this is a good opportunity to thank Gabriella and Shannon, who are on the education and advocacy team, for being with us today, and of course, the rest of the advocacy team who is currently in DC, who helps with this. So please join us next month, Tuesday, April 22nd, for the screening of Beyond the Bridge, A Solution to Homelessness. So this is a screening of a national film, but we're going to have a local panel with folks from MDHI and the City of Denver and CCH and a client to talk about their experiences to really bring home a national topic more locally. It is free. It's at the Tivoli Turn Hall campus or on Aurora campus. And so there's plenty of room, lots of spots open, and you can register on our website. And we'll go ahead and put that link in our follow-up email. So that's it for us. Join us next month for that. Join us for the whole series. Thank you all so much for taking time. It is not everyone who decides to take their evening on a beautiful day like this and spend it learning about homelessness. So thank you all so much, and we hope to see you next time. And thank you, Sean and Brittany. You guys are great.